But in the meantime, we are at 8 a.m., so we will get started for grand rounds. Delighted to have Dr. Andes and Dr. Shirley to kick us off. Dr. Andes.
Thanks. Well, it's my pleasure to introduce Dr. Dan Shirley. A bit of his background. He completed his medical degree at the University of Kansas, followed by internal medicine residency at the University of Colorado, and then an infectious disease fellowship and a master's in epidemiology at Cornell. We were fortunate enough, both the infectious disease division and hospitalist division, to recruit Dan to UW in 2013. And many of you know Dan for his clinical expertise, his work in COVID and infection control. He's done a large amount of work around COVID and emerging infectious diseases with the infection prevention group, and is now medical director for infection control at UW. In addition to his expertise in infection control, what you might not know is Dan has a lot of passion and expertise in care of underserved populations. And I'm excited to hear the intersection of those two worlds when he talks today about global health and infection prevention. So I'll turn it over to you, Dan.
Thanks, Drs. Andes and Schnapp. As mentioned, I'm going to talk about global health and infection prevention and how collaboration counts. I don't have any disclosures to report except to say that this isn't a COVID talk. And so if you're expecting that, sorry, it's going to be hard not to mention COVID in a way, but this is certainly not the priority of this talk. My goals are to define infection prevention, hospital epidemiology, and other confusing terms related to those. Go over and explain World Health Organization guidance for global health infection prevention, and illustrate the importance of collaboration in global health infection prevention and control implementation through a discussion about that through our UW and internal medicine global health pathway research experiences. That last point is long and also the majority of the talk. So these terms, you hear historically a lot about infection control. We like the more positive term these days of infection prevention. It obviously is the main goal is to prevent infection before they happen. So that term we use a lot. Hospital epidemiology also has kind of morphed into healthcare epidemiology as we expand into clinic infection prevention, et cetera. A lot of this is focused on healthcare associated infections or HAIs. This includes central line associated bloodstream infections or CLABSIs, catheter associated urinary tract infections or CAUTIs, surgical site infection, which is SSI, ventilator associated pneumonias or VAPS. VAE is ventilator associated events, which is related. And then we talk about MDROs or multi-drug resistant organisms, which includes C. diff and MRSA. Some of the other basic broad terms in infection control or prevention is standard precautions, which are those things you do for each patient to protect yourself and protect spreading around disease, which is like washing your hands, using goggles if you expect to have a spray or something like that of body fluids. Transmission-based isolation involves those things that we're all used to seeing on the door with, you have a particular syndrome or symptoms that you're watching out for. This is like tuberculosis and airborne precautions. This slide also highlights in some of our meetings in infection prevention, we can have whole conversations with just acronyms. So if you feel confused by these acronyms when you hear them, that's expected. The impact of healthcare associated infections is large. These lead to increased length of stay in the hospital, increased cost of care, and increased mortality, most importantly. And low and middle income countries likely have an increased rate of HAIs. This is widely known and suspected, although it's very difficult to prove because for the same reason they might have increased HAIs, they also have decreased reporting and ability to report. and general surveillance for these. So it's really thought to be a big problem, but obviously resources would need to be put in place to really know this for sure in every place. In the US, as far as hospital epidemiology or healthcare epidemiology, in the mid to late 19th century, this was a big time for infectious diseases where they realized that these could get passed around. So there's germ theory, asepsis, sterilization. Semmelweis really gets credit for being doing the first sort of hospital epidemiology when he realized that washing your hands would prevent some major OB, post-OB infections. In the early 20th century, there was more focus on transmission-based precautions, like some of these signs over here, preventing communicable diseases with some basic kind of stuff, prevention methods. In 1946, the Centers for Disease Control was established. And then in the 1950s, shortly after that, infection control programs were established in hospitals, involved nurses trained in epidemiology doing surveillance of infections in the hospital. Here at UW Health, we have an infection prevention committee, which is a multidisciplinary group. This is not just infectious disease or our team. This is spans the whole hospital, so involving surgery, anesthesia, everybody else, and a lot of the other groups that help do infection prevention, like environmental services and sterilization and cleaning groups. This group meets once a month. We sort of help review guidelines and approve policies that are broad. Our infection prevention team is a smaller group involving physicians like me in infectious disease, and also trained infection prevention practitioners. Currently, there's 9. These come from a diverse background of nursing, NPH, epidemiology, microbiology. So you can be an infection preventionist coming from lots of different backgrounds. And the work is involved in surveillance, reporting, and education. This is a lot focused on these HAIs that we mentioned. Each HAI also has some special attention in the form of work groups, bundle measures to help prevent them. You can see on the right, one of our big bundles related to surgical site infection prevention. This is just to highlight that these bundles can get quite complex. The evidence really is to include all of these as a general tool to prevent SSI. And the benefit is we can watch each of these to sort of record if we're doing all of these, the bundle is successful to decrease SSI prevention, for example. The group also is obviously involved in outbreak and exposure management. This is obviously right now quite graphic because of COVID-19, so you hear a lot from our group in general. And then one important point is there's sort of regulatory input to all of this infection prevention in the form of Joint Commission and Centers for Medicare and Medicaid Services. There are penalties involved related to hospital-acquired conditions in general, and infections, hospital-acquired infections is also included in that. So this is just foreshadowing some of the issues around reporting and sort of penalties related to having too many infections in the hospital. So do these kind of interventions that we do here translate globally, or does it even apply globally? Some of the issues that we have to kind of consider are the differences in priorities in different hospitals at different locations, and the resource differences between hospitals. Some of these things include, putting your focus on other communicable diseases that are causing problems just in your community or your nation, and then dealing with more outbreaks potentially than we have here at all times. This is also, of course, thinking about before 2 years ago, because everyone's dealing with an outbreak right now. Other hospital safety risks may be a higher priority, and then differences in money as it relates to training ability, different infection prevention teams or other teams in your hospital, and technology availability. And then how does the supply chain work? Is it dependable? And then, as I mentioned, there are differences in guidance from the hospital, but also, your local government or the federal government in the nation you live in, general oversight and penalties related to too many infections. And some countries have national guidelines, some do not, and then they're sort of forced to choose guidelines, which, that's where the World Health Organization or CDC is helpful, obviously. And then within a hospital, especially, you need some administrative buy-in to kind of put some effort and money towards preventing these infections. Another point, though, is that even though countries like the United States have ample resources like money, technology, infrastructure, we do still have HAIs and have a lot of room for improvement. And so there's a lot to learn from places where resources are less plentiful and how to use these resources efficiently to prevent hospital-acquired infections or infections in general. One way to highlight this is during COVID, these two maps are the rates of CLABSI by state, comparing 2019 to 2020. And, this is obviously during COVID. So states pretty much across the board had increased rates of CAUTI from year to year because attention was put elsewhere, essentially. Some of this is likely related directly to COVID because people have more lines and longer duration of catheters, but it also is likely just that everyone was focused on COVID and some of the other prevention mechanisms got sidetracked. So, it's just to note that the US is subject to the same issues as everywhere else. So in 2016, the World Health Organization created guidelines from evidence based on core components of infection prevention and control, and sort of divided these into national guidance and then acute healthcare facility levels. And they sort of outline these 8 major things that make up an infection control program. So one is to have a dedicated infection control program with the team involved. The second one is to develop and implement guidelines for infection prevention. 3, create education and training for healthcare workers related to infection prevention. Do surveillance of healthcare associated infections. Use multimodal strategies like bundles to improve practices. Have monitoring and feedback for infection prevention, and then monitor staffing workload, bed occupancy, and then environment, materials, and equipment. So these are a lot of words, but broad categories of things that a program should include. In 2019, they sort of expanded on this and made it more maybe user-friendly, at least some better specific guidance. So for creating a program itself, you should have one infection prevention trained focal person per 250 beds if we're talking about a hospital. There should be a dedicated budget, and then if you're a big hospital, tertiary care center, you should have a committee, much like the multidisciplinary committee we mentioned earlier. For the guidelines, these should be evidence-based, and standard operating procedures should be kind of written down and stored somewhere, especially as it relates to hand hygiene, decontamination of instruments, environmental cleaning, waste management, injection safety, worker safety, aseptic technique, triage of infectious patients, and then standard and transmission-based precautions. These are kind of the basic things that you would need in place to kind of start a program. For training, frontline and cleaning staff training in infection prevention, and then obviously training for the infection prevention team itself. For surveillance, have an active method of surveillance with feedback to your healthcare workers and administration. Multimodal strategies, at the minimum, have bundles to target standard and transmission-based precautions. And if you're a bigger hospital, have HAI-specific prevention bundles, kind of like the SSI Prevention bundle I mentioned earlier. And then monitoring, audit, and feedback, having someone to do that, and especially focused around hand hygiene, so that you're monitoring that. For workload, staffing, and bed occupancy, just have a system to manage space where you have control to make sure there's only one person per bed and there's space between the beds, and you don't exceed the bed capacity listed for your hospital. And then the basic environmental things are like running water waste facilities, hand hygiene materials at the waste facilities and the point of care, segregation of waste, ventilation, electricity with backup, decontamination and reprocessing space, and single isolation rooms. So even though these are a lot of things, it's kind of like the core of what should happen to prevent infection in a hospital. Let's see. So this takes us to our global health pathway. This was established in 2007 with a formal collaboration with Gemma University. And the first residents traveled in February of 2019. Obviously, this is internal medicine residency focused, but we also have had involvement with medical students, fellows, faculty from the Department of Medicine. And, you know, it obviously involved several things, education, including clinical training. Our system was really to set up a infectious disease consult service to offload some of those kind of consults for the team there. Obviously in Ethiopia, there are a lot of infectious diseases. So I think it helps to kind of integrate our residents with their residents and do some focused infectious disease kind of clinical work. And similarly, helping between our sites for research projects or quality improvement projects. The very first project was a qualitative study at Gemma University Specialized Hospital, which is the hospital for Gemma University. In June of 2017, conducted semi-structured interviews with healthcare workers about infection prevention, and then coded the responses for themes and divided things into barriers and facilitators. You can see on the right, the participants in this interview process, kind of a diverse group. The map on the left is to show where Gemma is, sort of the southwest part of Ethiopia. In the middle is a picture of the new hospital with some of the local inhabitants. To frame all of these quality improvement projects, we use the Systems Engineering Initiative for Patient Safety, or SEIPS model. This is a way to kind of think about the complexity of all these systems and divide them into these groups of things, which are technology and tools, organization, person, task, and environment. These things obviously work together and overlap to a degree, but it helps you kind of frame, you know, where you need to put some resources and focus. And this was developed here on campus by Dr. Carrion and her group. So for that first initial kind of interviews about infection prevention, some of the barriers that we found were availability of personal protective equipment and water, inadequate supply chain management, lack of isolation rooms, no dedicated infection control staff, high workload, hand washing issues. Some of the facilitators was that there was a new hospital with better water access. Some budget was available. The cleaning by environmental services was good. And generally speaking, there was some awareness around some of the issues related to infection prevention. From this, we sort of worked with the team there, but primarily they developed a kind of a little bit of a structure for an infection prevention team. It's involved a physician lead, an IPC team lead or coordinator, and then liaisons on wards. So there started to be some structure for infection prevention there. We hosted Gemma University Hospital leaders for infection prevention in July of 2017 here at UW. This was the physician lead in infectious disease, Dr. Yoma, and microbiology, Dr. Helen Seged. On the right, you can see the picture of their microbiology lab with Oromo on top, Amharic under that, and then English under that. So the science were actually in English, and the teaching kind of language there is English. So that certainly helped for our clinical work. The next project was utilizing the SEIPS model to guide hand hygiene interventions out at a tertiary hospital in Ethiopia. So we embarked on this project in 2018 at the end of the year with a baseline assessment. You know, from the initial barriers study, we could tell that hand hygiene would be an impactful thing. So discussions with the groups there, this was kind of targeted based on that assessment and WHO priorities. The first kind of thing was to do a knowledge and attitudes questionnaire and some baseline observations of hand hygiene, and then qualitative interviews again. As a reminder, there are 5 moments of hand hygiene. So before you touch someone, before you do a procedure, after you do get exposed to something, after you touch a patient or their surroundings. And, this is kind of a table one about who was involved, but also some of the knowledge and reported hand hygiene. So just to note that that arrow is pointing to what percentage of our group of 250 people had training in hand hygiene in the last 3 years. So it's pretty low across the board, somewhere around 14%. It's a little bit of differences between nurses, physicians, and lab techs. And then the hand hygiene practice and knowledge with the circle. The reported hand hygiene was high, around 70%. And the knowledge mean, really just to note, there's some minor differences between the different groups of providers. More than the number itself means much, but we'll go into that. As far as attitudes from these interviews, I highlight a couple here. The first one is whether they think they're a model for hand hygiene for other healthcare personnel. And these are, a Likert scale. So the higher number means they feel strongly that they are a model. So physicians felt more strongly than the other groups as being a model for hand hygiene. The second arrow is pointing to whether they think hand hygiene reduces mortality. And similarly, some differences between the different types of providers. And then the final arrow shows whether they think hospital-acquired infections is valuable as a role for healthcare service provider. And then just again, some differences between the groups. Overall, obviously, it's above 3, so veering towards agree, but in the middle. As far as barriers and facilitators from this, we divided these again into the SEIPS categories, and then between the barriers and facilitators. Lack of functional water facilities or hand rub soap, those types of things, and lack of gloves were noted again. Lack of hand hygiene monitoring and surveillance was a common barrier. Lack of formal training, awareness about hand hygiene, high workload, too few hand hygiene posters, and the materials to do hand hygiene are kept outside of the patient rooms. These are obviously barriers like before that we can target to direct our interventions. On the right side is the facilitators, things that are going well. These include dispensers that are present, increases the ability to have hand rub available. And in the pocket hand rub, above that, I didn't put an arrow by, but another facilitator. Communication was good between healthcare workers about patient safety in general, and that there were some hand hygiene posters around. So phase 2 happened in August, September of 2019. Like I mentioned, based on the barriers especially, we focused efforts on an educational campaign with posters promoting hand hygiene, television messaging strategically placed through the hospital. Resource and environmental changes included installation of 400 hand rub dispensers in a more usable locations, and improvements in supply chain, which included having more dedicated general supply chain of what they already had, but also starting to wonder whether a local supply might be good. And then training involved IPC team training in health or hand hygiene, along with training some ward-based focal persons, and then nursing staff directly. So phase 3 was a follow-up. And this is notable that it happened in May through August of 2020 when COVID was happening. So this is a graph of COVID across the world, COVID cases. And, we're talking about the very beginning of it. But if everybody can remember back at the beginning, there was a lot of attention around lots of things, including hand hygiene. And, information coming from World Health Organization, CDC, everybody about sort of a emphasis of hand hygiene. So this definitely applied to Ethiopia and Germany Hospital also. So definitely a lot of attention around hand hygiene along with some other things to try to prevent COVID from causing a big problem. And I mentioned that because the observations and follow-up about the sort of 5 moments in hand hygiene are outlined here. We compared the baseline, which is the darker blue, to the post-intervention hand hygiene compliance. Obviously low based on the baseline observations at all 5 points. On the far right, you can see the total rates of hand hygiene, which was 9.4%. And then the lighter blue is after the intervention, which happened to be at the time, it was a lot of attention related to COVID. So much higher rates in total, 72% overall. And we also divided this amongst the different groups. It's notable that, the absolute change for nurses and midwives between baseline and post intervention was very high, and just a little bit of a less of a difference between baseline and post intervention for physicians. So the conclusions from this are improvement in hand hygiene requires a multifaceted approach. You can obviously find lots of guidance about hand hygiene from WHO, CDC, et cetera, but there are local and facility specific issues that do have to be accounted for. And, it helps focus your interventions if you know what's going on locally. Increased resources and attention lead to increased adherence to hand hygiene. So COVID-19 obviously influenced the hand hygiene rates. And, but there's kind of you can't increase the hand hygiene rates if you don't have the supplies to do it or the knowledge that you should do it. So having some things in place to allow people to do the right thing is certainly an important part. And a steady supply of alcohol hand rub certainly is one of those things which allows people to do hand hygiene. And having a local supply, I'll talk about more about the importance of having a sort of robust and modifiable supply chain in all of this. A stable infection prevention team is crucial to improve and maintain hand hygiene. So education and other changes can be deployed more rapidly to respond to unpredictable events like COVID or observe changes in compliance. So if you have a way of surveilling that people are doing hand hygiene or not, you can obviously make a change if you have a team to do it. So switching gears slightly, the next project after the hand hygiene was to evaluate barriers to facilitators of surgical site infection prevention. This was kind of the next logical step in discussion with the group there and just general priorities. And this slide is going over some of the background at Gemma University Specialized Hospital related to this. In 2006, there was a initiative by the Ethiopian Ministry of Health called Saving Lives Through Safe Surgery. And then shortly after that, a group sponsored by Lifebox did a pilot of a clean cut program, was what it was called in Gemma. It was a 4 to 6 week baseline observation, team building and process mapping intervention, and then a 6-month implementation focusing on the direct perioperative period with skin preparation, sterile field maintenance, instrument sterility, antibiotic administration, gauze count, and surgical timeout. This was, a safety intervention overall, but certainly overlapped some of our infection prevention goals as well. Shortly after that, so late 2016 in Ethiopia, there was political instability and a lot of protests, and some of this was centered around Gemma. Because in 2018, the prime minister, who was originally from the Gemma area, took over power and established a new government. So this is just to highlight that global health in general, and definitely in the hospitals we were dealing with, are subject to kind of instability, and that does influence some of these programs, obviously. So in that setting, in March of 2019, we started this project with interviews with 20 healthcare workers that involved 10 surgeons, 8 surgical nurses, and 2 anesthetists. These were semi-structured based off of WHO's 2018 SSI prevention guidance, and still, again, using the SEIPS framework. We basically, similarly as prior projects, wanted to evaluate the current prices and barriers and facilitators to doing SSI prevention. The other part of this was observations of 19 surgeries done by trained IPC team members in GEMA of the main OR and OB-GYN OR. This observation form was created from that same WHO guidance in 2018, but also incorporated some of the UW Health SSI prevention bundle that I went over earlier. It's kind of a combination of those things. And again, you can see divided into the different SEIPS sections, some of the barriers. So we have talked each step about insufficient water, soap, and antiseptics, supply of gloves, lack of protocols and guidelines related to SSI prevention, the lack of involvement by infection prevention in SSIs prevention, high OR traffic, ventilation, insufficient training on SSI prevention, and lack of patient follow-up after procedures to know what happened, and then issues with emergency cases in the time to sort of prep. Some of the important facilitators that we found that they had sterile instrument indicators, water and antiseptics were available to an extent. There's a culture there of speaking up about breaks in sterility. There's good environmental services about disinfecting the room and table. The ORs are separate spaces. There's knowledge about SSI prevention in some staff. And then, you can see a smattering of other facilitators. For the observations, this compares the reported adherence with the observed compliance from the observations. And on the left, you can see some of the SSI prevention measures that we had to review. And there's some differences included. They don't do MRSA screening in general. So that was both the same between reported and observed. The pre-op bathing was not high in observed compliance and kind of mixed location in the reported adherence. Antibiotic timing and choice lined up and was appropriate. The hair not removed is a goal, and there's kind of mixed reported adherence to that. And then the actual observed is that most of the time they don't do this in the OR appropriately. They appropriately don't do this in the OR. Intraoperative stuff was all really good about surgeons scrubbing, using sterile gloves, having the instruments documented as sterile, and then incision site skin prep, both in reported and observed. This likely relates to having this culture in this recent project related to this sort of intraoperative period. And then postoperatively, wound care order submitted was really the only way we could tell if something happened postoperatively as far as monitoring the wound. And reportedly, the surgeon does orders, but sometimes they said it doesn't happen. In the cases that we observed, it did happen. So some of the strategies to address the barriers and improve SSI prevention from this project were to clarify and disseminate institutional SSI prevention guidelines. That was obviously a big barrier. Have formal SSI prevention training for new OR staff, have OR staff collaborate with the infection prevention team, increase the signage about zoning and movement within the OR, and improve the SSI tracking and reporting. So as a general overview of our collaboration with GEMA, we had a formal partnership with them. We did bi-directional sharing of ideas and tools related to infection prevention team formation, hand hygiene prevention, or hand hygiene, SSI prevention, and microbiology kind of techniques. We worked together to understand barriers and feasible interventions for those barriers and learn efficiencies and priorities from each other, especially as it relates to implementation techniques, research and quality improvement projects, and clinical training or education. And an important part of all of this is having a long-term collaboration. So more than just having a partnership, to have some long-term look of, what can we work on together in the long term. And this includes, travel and sort of meeting with each other. And we did host also the leaders of Gemma University in September of 2019. That's the photo here. And collaboration generally speaking leads to further collaboration, which is great and a big bonus from all this. We had additional agreements with Mekelle University and Addis Ababa University, or Black Lion Hospital, that sort of rose up from this. The second year that residents traveled, the clinical and research rotation was actually at Black Lion Hospital in the capital. We had collaboration with UW Pediatrics related to a project around neonatal sepsis that a pediatric infectious disease fellow did. And that was great and very successful. This all also moved us into antimicrobial resistance. We participated in a systematic review and helped with the clinical implications with colleagues from Armor Hansen Research Institute in Addis that evolved out of our partnership with Dr. Alam Seged. He had moved to that new institution. And that kind of led to new projects related to resistance and helping with antibiograms or resistance patterns at different hospitals, and maybe even a sort of view of the national resistance of antibiotics. We also got the opportunity to help discuss Ebola, COVID-19, and pandemic preparedness with leaders in Ethiopia. I will highlight the sort of collaboration related to Ebola, because again, there's kind of a sharing of ideas. So summer of 2019, Dr. Siraj and I sort of toured and helped kind of work through some of the flow issues related to travel. Addis Ababa Airport is a very large hub for Africa. And at that time, there was an outbreak of Ebola in the Democratic Republic of Congo. So there's a lot of attention about how would we find someone that might have Ebola, and then what would we do with it, which is certainly a topic for the United States as well, sort of coming off the 2014 scare of Ebola. So on the left is the airport thermal scanning. If someone did scan, they would go to the top right to get some more questions and PPE. And then some discussions about transport to the bottom right, where there was an Ebola treatment center off-site. So, how do you get them there, that type of stuff. We walked through, and then we walked through the actual treatment center, which certainly brought up a lot of lessons that were helpful for us too. The airport and country screening, as it relates to Madison, is more about generally, how would we know if someone in our area needed to be either ruled out or treated for Ebola? What do you do with them awaiting transport? How do you get a patient with this type of disease from one place to another? What happens if something breaks down or there's traffic? Do you have a dedicated building for this, or do you retrofit like we did? Patient traffic, either through your hospital or within the unit, working with limited space, shared bathrooms, PPE, and waste. How do you deal with that? And what's the ventilation situation? And these are all very pertinent because we, in 2014, dealt with this in F65. A lot of these issues were certainly issues then and ongoing issues as we sort of plan for the next thing. We have a special pathogens team that we have ongoing training. And around that time, just after that visit, we had a formal kind of kickoff, let's say, January of 2020. At that time, there was kind of initial notes about novel coronavirus in Wuhan. And we used that as an example of why we need to keep some kind of ongoing preparation and thinking about all these things that we discussed in Ethiopia. And of course, that actually became something. So that pathogen was a novel coronavirus. And then shortly after that, we actually had our first PUI here at UW Health. And then shortly after that, the first actual case. And our special pathogens team actually, because of experience and some thought about this, I guess. They were certainly instrumental in the initial care testing protocols related to those first, rule outs, but also cases of COVID. And it was certainly helpful to incorporate lessons learned related to Ebola, especially transport screening, cohorting, ventilation, and patient movement within a hospital, as we were trying to figure out how to deal with the initial cases of COVID. These topics that we've discussed through this presentation all became very much more local through COVID. As everyone remembers, I mentioned that places like the US, we often have a lot of resources, but in this instance, we also suffered some major resource limitations that other countries have intermittently all the time. So it was hard to find masks. There was discussion about, how do we make our own cloth masks, which is, a big global health topic in general. What is face shields? Can we make our own supply because we can't get them? Same for hand sanitizer. Here we started making it locally when there was shortages. These are all very reminiscent of some of the global health topics. Local and distributed production of PPE and other supplies, hospital space limitations and triage of care, and then a lot of ventilation discussions. Again, reminiscent of, treatment when you don't have actual airborne or negative pressure rooms in other countries. What can you do for ventilation? Like pushing open the window, that's very impactful. And another kind of global health related topic is, similarly, we can't just be isolated in the United States. We now know, of course, that if we control it here, great, but if it's not controlled everywhere, then we have variants and that we get to deal with also. So, ignoring the global picture certainly does not work. And so all of this topics that I was mentioning is super important looking forward. And similarly, there's this brewing other problem of antimicrobial resistance, which, we're trying to think about how can we be helpful. And this, like COVID, is a global problem. If we control it here, great. But if we don't help and work on it everywhere, then we're also going to suffer the consequences in the long run. So keys to global health collaboration, having shared goals of improved clinical care, quality improvement and research ideas and education, with some integration of all these things between learners from both areas. Exchange of ideas. It's very helpful and important to have long-term mutually beneficial associations and projects, bidirectional travel with a purpose, cultural awareness on both ends, creative use of technology. So, it's not that you're just going there for a few weeks, but you can keep projects going remotely. Implementation issues in resource limited settings can inform implementation in resource rich settings. That is kind of a highlight of this discussion. And all countries are subject to resource limitations, obviously, and thinking about how can we manage that in the future. Identification of key stakeholders and positions we have found to be of massive importance, especially if you're trying to set up a formal team that can keep going over time, like infection prevention. And a general acknowledgement that priorities are influenced by money and time. And although the difference may be there for money and time, the same things influence what you can do. And then my final thoughts are that prevention of infection is complex. Organized infection prevention teams are crucial to react to new infections or outbreaks of old infections. Resources must be timely and directed, and local control is not enough. We have to think globally about these issues. Obviously, COVID-19 and antibiotic resistance highlight the interconnectedness of the world, and all of this highlights how important global health collaboration is moving forward. Some thank yous definitely to the Gemma University team, Dr. Yoma, Besha Galana, and Getnet, and the whole infection prevention team there. Addis Ababa University and Black Lion Hospital, Dr. Alan Seged, and from the Public Health Institute, Bian and Mogus. Our group here in internal medicine, The special thanks to Dr. Siraj and Safdar, Dr. Cavalier, Lang and Abby are sort of glue for the whole program. And so medical students really spearhead some of these projects, especially Lee Berman, and then our team here, of course. So with that, we'll take some questions.
Great. Well, thank you so much. Appreciate the overview. One question. So hand washing versus gel. Better, worse? What's the evidence?
Yeah, it's a good question. I think at the end of the day, whichever you can manage, and that might be different depending on which hospital you are, what resources you have. So in Gemma and maybe Addis, it has a lot to do with the dependability of water. And sometimes if you ever have to say the dependability, you might not have water or soap, then you still need a backup of alcohol hand rub. And so that is probably the reason that most places choose alcohol, but then that's subject to having a kind of consistent supply. And so I think, distributing the supply chain for alcohol, but all of these things like PPE is definitely a topic that needs more attention, so that if one place goes down, in our instance, if all the masks are made in China, and then China has the beginnings of this outbreak, then it causes a problem worldwide. So in the US, we obviously can take that lesson of making some of the stuff here.
Yep. Another question, what's the evidence for and against wearing lab coats, ties, which you're wearing now, as potential fomites in the healthcare setting?
Yeah, exactly. I am an increasing believer in not wearing ties, actually, but I thought I should wear one today. But you won't see me with a tie most of the time. And you'll likely see me with my sleeves rolled up if I'm wearing a shirt. I think one of the things that's interesting is from COVID is seeing more scrubs, which I think a lot of people in infection prevention really think in a perfect world, you'd go to the hospital in your normal clothes, change into scrubs, take those scrubs off to put your normal clothes on to go home. That was a topic early in COVID where everybody was worried about their clothes and shoes. And, there was so many stories of people taking all their stuff off before they went in their house and burning them, or not burning, but cleaning them. And that was probably, of course, overshot, but that's the same, I think, philosophy that I think we do believe that, stethoscopes, just pay attention and clean them. But clothes is definitely a questionable thing about carrying it, because some things like ties and other lab coats are sometimes hard to clean.
So another question, let's look even locally. How you can come up with your guidelines and bundles, but you still need to get a culture change and get people to adopt and carry out those practices. So how do you manage that culture change? How do you facilitate that?
Yeah, I think example is doing this in Gemma. There's some stuff already in place, and as far as interventions and infection prevention, but it's a little bit disjointed. And so starting from scratch to say, we need a team that has some authority and resources to actually organize this. And even then it's difficult, because you can do projects like we did, but there's not appetite to do the sort of aggressive surveillance. And so implementing a bundle measure like this complex surgical site one I outlined here, you only want to do that if you can also then follow up whether you're doing it right or not. So that is overwhelming if you just throw this bundle measure without doing all that other background stuff, like you said, of convincing people that this is important. It's one thing, it's like a good and bad thing to have this kind of oversight and the threat of penalties. But it does motivate at least shifting your priorities to the things that they're asking you to really focus on. So, if you're an optimistic person, you look at that as like a positive to sort of We need to really focus on these things, and everyone should care about it because our hospital is going to get fined. But that's really not the main priority. It's mostly about patient safety. And I think in day to day, it's hard to imagine my patients at risk for a hospital-acquired infection, but that is definitely true. And a lot of this is looking back and seeing the damage after the fact, as opposed to thinking about my patient has this line that they don't need and is creating this kind of consistent risk. So I think that's kind of the focus is some of those things in those bundle measures of thinking about prevention instead of just control after the fact.
Okay. All right. What is the outlook for? So what changes do you anticipate, or do you anticipate changes in hospital infection after COVID goes from a pandemic to more an endemic situation?
Yeah, I think 2 years of a pandemic allows us a lot of reflection, and I think we also get a lot of looking back about which things do we actually need and which things weren't as helpful.
Mm-hmm.
I think a lot of the talk right now, as we sort of have cases going down, is how do we loosen up some of these things in general in the community and our hospital, but which things do we need to keep, like masking when there's still a significant amount of cases around. There's so many things related to visitors and testing and all these things that we sort of have to shift as the cases go down, as we'll have hopefully endemic, or if it's at a low level somewhere and there's sporadic bursts of cases. Hopefully we have some trigger of that relies on monitoring and testing to know this is the time where we really need to do something, whether that's increased masking or just general education that this is happening. So I think that kind of, what do we do for surveillance to allow us to know when we reach the threshold that other interventions need to happen again. In the short term, there's a lot of discussion about how do we kind of wind some of these things back without making it more confusing, which of course is the whole trick. So.
Great. And then I know Dr. Andes has a question. And
I guess related, to what we're doing in the hospital now with COVID, how do you think the changes in the community and in-home practices will impact things here in the short term with COVID?
Yeah, it cut out a little bit, but I think you said how are the changes in the community going to influence what we do in the hospital?
I think it's the opposite. What are we going to be doing? Are we going to be focusing on any home infection prevention, especially for our immunocompromised patients?
Yeah, I think as we've gotten further along and Omicron happened, the difference between immunocompromised and not immunocompromised has become even more graphic, actually. So yeah, I mean, I think we're trying to sort that out about both within the hospital, how do we protect, the immunocompromised that are here, but also that's a huge issue in the community too, as everyone else is like, well, I had infection or I've had all my shots and, I feel like the cases are low, so I'm gonna go do a bunch of stuff. I think that sort of forgets about people at major risk from bad things, from getting infection who didn't respond to vaccines. So definitely a focus right now. And it is really impressive because I think there's just massive differences between people saying like, this is not a big deal, it's very mild, which is a big discussion related to schools and kids and everyone else. And then there's kind of, very risky, high risk situations of transplant and stuff those things are happening at the same time. So I think it is changing things.
Okay. All right. Well, thank you, Dan, so much. Look forward to seeing the cow pictures at some point, or maybe in person. Thank you for all of the work you do on behalf of the hospital and global health as well. Appreciate it.
Thank you.
Okay. Bye-bye.